Hello, today we are going to talk about the use of CT angiography and perfusion in the evaluation and treatment of acute ischemic stroke patients, addressing both standards and potential pitfalls. My name is Edward Sloan. I work with fern.org. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois. I also am Medical Director for New Rose Healthcare Management, helping the emergency department at Roseland Community Hospital in Chicago, a safety net hospital. And I serve as Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This information is being presented at the Clinical Decision Making in Emergency Medicine meeting, June of this year. I want to give my thanks to Joan Esbrey-Cullen, Andy Godwin, Andy Jagoda, Ginnia Ports, and Scott Silvers, with whom I've worked at this good meeting for several years. I have no financial conflicts. I serve as the Fern President and Board Chair. Let's talk about some Let's talk about some special considerations in AIS neuroimaging. The first, of course, is MR imaging and perfusion studies. So what is the role of MR imaging and perfusion studies for acute ischemic stroke patients? Remember, MR does detect hemorrhage and stroke etiologies quite well. And MRA has a similar utility to CTA, but often is used more subacutely, that is, not at the time when a consideration is made for the use of thrombolytic therapies or EVT. We know that MRA can be done without gadolinium contrast. We know that MR DWI does detect hyper-acute ischemia with good sensitivity, specificity, and accuracy. And we know that it is possible with the use of DWI and FLAIR studies to identify patients who would benefit from EVT. We also know from the Diffuse-3 study that the diffusion-perfusion mismatch on MR does successfully select patients for the extended window for reperfusion therapies. And we know that MRVs are useful when venous occlusion is suspected. So, MR neuroimaging and the ischemic penumbra images. What does an ischemic penumbra or a PWI-DWI mismatch look like? This happens to be a 40-year-old female, left-sided weakness, NIH stroke scale, which is quite high, suggesting a likely LVO. In fact, was due to a right internal carotid occlusion. And you could see what's important here is the yellow ischemic penumbra identified on MR. This is another example where the penumbra is identified in yellow. A 31-year-old male, sudden left-sided weakness, NIH stroke scale high again of 16, a right internal carotid occlusion. And so you can see in these two patients who had carotid occlusions as a cause of their stroke, with MR, you can identify an ischemic penumbra as identified here in yellow. And you'd say, well, what was identified at the time that they did a non-contrast CT, a CTA, or CT perfusion? Remember, in patients in whom the likely scenario of a middle cerebral artery being occluded due to some thrombus or embolus, you might use the MR as an alternate therapy or diagnostic for determining the cause of the stroke in patients that are not typical, those who are young, for example, as compared to older patients. So what about neuroimaging in young acute ischemic stroke patients? How does stroke evaluation differ in young AIS patients? Well, in younger patients, you need a heart-to-head evaluation. You need to go all the way from the brain to the neck to the heart to determine a possible etiology for stroke, because stroke is not common and is not often related to an abnormality in the cranial cerebral vascular vessels. So you need a non-contrast CT and a CT of the head and neck, an MR DWI will show an apparent diffusion coefficient, and the FLAIR study will assist in determining what the likely stroke ictus onset time was. An EKG is required for young stroke patients, as well as a heart echocardiogram using a TTE and a bubble study for identifying any areas where there's flow between chambers that is abnormal. You need a lab assessment of lipid disorders and atherosclerosis. You need to look at multiple vascular territories, not just the head and neck, because this stroke in a young person may be related to some type of vasculitis or embolic phenomena. And we need to consider fibromuscular dysplasia, or FMD, which is a non-inflammatory cause of vessel abnormality. Now, once you determine the cause of the stroke, strokes in young patients have similar patient management as those who are older and diagnosed through more standard tests, NCCT, CTA, and CTP. So what about this FLAIR study? A FLAIR is a fluid attenuated inversion recovered study. It's an advanced magnetic resonance imaging sequence that reveals tissue T2 prolongation with cerebrospinal fluid suppression, allowing the detection of superficial brain lesions, such as those cortical lesions that might be detected with the VAN assessment. So it's a useful tool in the diagnosis of acute ischemic stroke because it can help to estimate the onset of the acute ischemic stroke within 6 hours, which may enable more patients to receive thrombolytic therapy. So the MRI FLAIR is good at detecting the core infarct at less than 6 hours. And when the FLAIR is negative, but a perfusion defect is noted, then the stroke ictus is likely to occur greater than 6 hours, but still within the time frame where EVT, aggressive therapies, may be useful. In other words, if the FLAIR is negative and there's no demonstration of a core infarct, but an ischemic penumbra is identified, it is then possible to then refer these patients for more aggressive EVT therapies between 6 and 24 hours. What about neuroimaging cost? We made a mention of this, but let's consider it. Are the cost considerations of different neuroimaging strategies important to us as we consider both the acute costs and the long-term costs in patients who are disabled from stroke? So a comprehensive CT approach does create the most value. That is, the NCCT, CTA, CTP is more cost effective than waiting and utilizing MR therapies. CTP testing is especially useful up to 6 hours following the ictus, and the radiation risk is especially low in patients who are less than 70 years young. And we know with the neuroimaging that we've demonstrated here and the multimodal CT, you can establish efficient workflows at comprehensive stroke centers that give you the best cost bang for your buck. Now, what about endovascular therapy? So what's the status of endovascular therapies in acute ischemic stroke patients? So endovascular therapies are really in search of the optimal way to treat large vessel occlusions and large ischemic penumbras when there is a small core infarct. We know that perfusion studies help in suggesting when EVT might be therapeutic, especially beyond the 6 hour window. We know EVT may be useful in part with the use of intra-arterial thrombolytic therapies. We know that there are second generation devices, mechanical devices that exist that allow the clot to be removed successfully. We know in patients with an aspect score less than 6 and an infarct size greater than 70 mLs, these patients may especially benefit from endovascular therapy, especially because they define a larger patient group. We know that EVT beyond 24 hours may be beneficial in treating the ischemic penumbra, especially when considering posterior stroke. And we know that the use of endovascular therapy in mild stroke patients, those with an NIH stroke scale less than 6, may benefit from EVT. So in summary, EVT is available for treating patients who are of benefit because they have a large ischemic penumbra, especially those who are beyond the IV thrombolytic therapy window, in patients who may benefit from intra-arterial thrombolytic therapy, in patients who may benefit from clot removal using second-generation devices, in those who are defined as having the best likely outcome with aspects and infarct size score, and in those in whom treatment beyond 24 hours it may be of benefit with EVT, including those with small or mild strokes. Thank you for your time in learning more about optimizing the care of patients who present to the emergency department with acute ischemic stroke. You can scan this QR code to find out more about our social media links, and you can send me a question to fern.org@gmail.com or edsloanmd@gmail.com. Once again, thank you for your participation in this Fern educational effort. Have a good day.